Welcome back to the Ninja Nerd Podcast. Today we're talking about plasma cell disorders, and we've got only one case to go over. Shouldn't be a crazy difficult topic, but we'll go through it and very thorough like we always are.
Yeah. There's a couple different ones, like types of plasma disorders, but we just have to kind of figure out which is the most likely one. And I think that's the big goal here.
Well, let's get into it.
All right, cool.
All right, so here we go with our first case, our only case. We have a 65-year-old male presents with persistent fatigue, bone pain, and recent episodes of confusion. The patient reports worsening fatigue over the last 6 months with intermittent low back pain that has become progressively severe. He also notes increased thirst and urination over the past 2 weeks. Recently, he experienced confusion that resolved after hydration. He denies fever, chills, or recent infections. His weight has been stable. For his past medical history, he has a history of hypertension, hyperlipidemia. He is on medications for those conditions, which are lisinopril and atorvastatin. For his exam vitals, BP is 140/85, heart rate is 92, temp 98.6 Fahrenheit, respirations are 16 per minute, and his O2 sat is 96% on room air. General, he appears fatigued but in no acute distress. Cardio, normal S1, S2, no murmurs. Respiratory is cleared bilaterally. Abdomen, no organomegaly. Neurologic, alert and oriented, no focal deficits. MSK, tenderness to palpation over the lumbar spine, no deformities. And his skin, there are no rashes or pallor noted. We have some labs incoming. Hemoglobin is 10. Calcium is 12.1. Creatinine, 2.3 with a baseline of 1. Albumin is 3, and his total protein is 9.5. We also do an imaging study. It's a skeletal survey, and we find lytic lesions in the lumbar spine and skull. Kind of explain some things going on here.
Yeah.
Now, how would you know to go for a skeletal survey here?
I mean, any kind of presentation of like bone pain and then just these generalized systemic symptoms such as fatigue, maybe like low-grade fevers and things like that, especially with tenderness to palpation over the lower lumbar spine, I would just do x-rays. And so skeletal surveys could be kind of like a full body x-ray. It could be series of x-rays. I think all he would need is an x-ray or a CT scan of that kind of like spine and see if you can find out the potential etiology, because pain is not just always lytic lesions in this case. It could be other things. There could be fractures, there could be some type of spinal cord abnormality, etc. So I think we just happen to get a skeletal survey, which is just basically a fancy word for a bunch of different x-rays. If you have a suspicion that there's some type of like lesion, lytic lesion going on. So,
but in this patient scenario, you're like, well, it's probably not MSK in nature because it seems like there's some systemic involvement.
Yeah, there's definitely a lot of systemic involvement here. That's for sure. All these other symptoms and kind of complaints that he has, such as that worsening fatigue, that's concerning. The episodes of confusion that improved after hydration, the polydipsia and polyuria. These are all kind of like interesting features that doesn't suggest kind of like a random MSK kind of issue. So yeah, I definitely think that there's something else going on. Plus his labs, he's got a lot of derangements that are suggesting other kinds of abnormalities such as anemia, hypercalcemia, potentially depending upon how acute this changes in the creatinine and AKI, but he's definitely got some renal injury. And then his protein gap, which we'll talk about a little bit later, which is the total protein minus the albumin. That's also pretty high. It's not supposed to be greater than 4, and right now it's 9.5 minus 3, which is...
So what would that protein gap suggest?
Oh, that tells me that there's lots and lots of proteins inside of the bloodstream, and it's not albumin. So if you look at like, there's something called a serum protein electrophoresis, which we'll talk about. It just takes all the blood plasma and basically all the proteins that we have in our blood plasma, puts it into these like little wells, and then we kind of have an electrodes, like a negative and positive electrode at the end of it. And proteins are usually negatively charged, so they'll move towards the positive electrode. And how they separate is dependent upon the desire to get to that positive charge or based on their weight, etc. And so they separate out, and you get albumin. So you can remember the shaka. In the shaka,
okay,
it always goes...
It's perfect for you.
Yeah, exactly. Shaka is always albumin, alpha-1 globulin, alpha-2 globulin, beta globulin, and then gamma globulins. And so this is usually like the normal shape of the serum protein electrophoresis. So when you have an increased protein gap, one of these things, besides the albumin, is elevated, and that's what we have to try to figure out.
So within the kind of the umbrella of plasma cell disorders,
Yeah.
what are the conditions or the differentials that you'd be thinking about within this kind of umbrella term?
So some patients, if they have an elevated protein gap greater than 4, which is 9.5 minus 3, what is that, 6.5? So it's definitely greater than 4. Definitely tells me there's lots of excess proteins. It doesn't tell me which kind, but I know for sure there is. And so when I think about that, I think about 3. MGUS, which is monoclonal gammopathy of undetermined significance. Probably why people call it MGUS.
Yeah, we're going to go ahead and use that term.
Yeah. Waldenstrom's macroglobulinemia, which is kind of rare. And then the last one is the most common, which is multiple myeloma. And so there's one of the big things that screams here to me is the fact that this patient has the CRAB criteria. And the CRAB criteria is hypercalcemia for the C, R for the renal failure, A for the anemia, and B for the bone pain or lesions. And look what this patient has. Calcium, 12.1. That's pretty significantly elevated. It's greater than 10.5. Mm-hmm. There's one. Plus he has symptoms. I'm pretty sure like the polydipsia and polyuria, and the confusion is because of his hypercalcemia, because you got to remember the stones, bones, groans, thrones, psychiatric overtones.
Sure.
The psychiatric overtones is probably the confusion. And then the thrones is his polyuria because of the DI. R, the renal failure, look at the creatinine, 2.3, baseline 1. So there's an injury there, probably because of these proteins. In multiple myeloma, they make lots of these different proteins. They're they're antibodies, which are going to be IgG or IgA. But you also make these like little guys called light chains, and they're called Bench-Jones proteins. They get into the bloodstream, move across the glomerulus, and cause injury to the kidneys. And so you get an acute tubular necrosis. So that's probably that one. And then the next part is the A, anemia. So hemoglobin is 10. This is a male.
Male, yeah, sure.
Less than 13 is considered to be an anemia. Yeah, this one's usually normocytic. They didn't give you the MCV, but it's usually a normocytic anemia. And then B is the bone pain or the lesions. And so we have the skeletal survey and the clinical presentation of that pain over the lumbar spine that definitely suggests that this patient has these lytic lesions.
So how do you differentiate each of these conditions? And you said multiple myeloma being the most common.
Yeah.
But how about if you consider them as a whole, how do you differentiate them?
So multiple myeloma has CRAB criteria, and then they have a lot of these proteins. So all of them have increased gamma globulin. So remember that Shaka sign?
Yep.
So albumin, alpha 1, alpha 2, beta, and then gamma. So gamma globulin is usually the ones that contains the antibodies, IgG, IgA, IgM, IgE, IgD, right? In multiple myeloma, MGUS, and in Waldenstrom's, all of them have an increased gamma globulin. We call it an M spike. So it's kind of a monoclonal protein spike is what it is. It just means you have a lot more of them than a normal person. So the M spike represents that there's more gamma globulins. If the M spike is less than 3, and it's in grams per DL, that's not as high, and that usually, if the patient has no CRAB criteria, so hypercalcemia, renal failure, anemia, bone pain, it suggests MGUS. So MGUS is kind of like a tweener where it's a pre-malignant condition. Like you're making lots of antibodies, but not enough that it's causing organ damage. And so M spike less than 3 means you have lots of gamma globulins, primarily IgG or IgA and light chains, but it's not at the point where it's greater than 3, meaning it's probably not at the point where it's causing organ damage. So that's MGUS. Multiple myeloma is you're making a lot of these IgG, IgA, and light chains, but there's too many of them. The M spike's greater than 3. There's enough of them to start causing organ damage, such as the CRAB criteria. So CRAB criteria, M spike greater than 3, multiple myeloma. No CRAB criteria, M spike less than 3, MGUS.
So is MGUS, due to its being a pre-malignant condition, can that basically transition into multiple myeloma?
Yeah, so I think it's a disease of, I don't mean to be rude, old people. So the older you get, the higher the chance of it is. So usually we see this in people older than 70 years old. And so it's not to be negative, but like think about this. There's a 1% chance of converting to multiple myeloma every year. So the chances of you developing multiple myeloma from MGUS, there's probably a better chance of you dying from other things before transitioning into
very low chance.
So it's important to observe them, but MGUS is usually just one of those things that you just observe. You don't really do much about it. You just try to keep an eye on that SPEP and watch out for CRAB criteria, because if all of a sudden that M spike goes up, Greater than 3, they develop Crab criteria. They're now in a state of multiple myeloma. There's another one in between. There's a tweener between that one. It's funny. So there's
Lots
MGUS.
of tweeners.
Yeah. MGUS, multiple myeloma, right? Crab criteria, greater than 3. No Crab criteria, less than 3. If you go in between where you have no Crab criteria, but an M spike greater than 3, that's called smoldering myeloma. And you're literally almost at the point where if you start to develop Crab criteria, you develop multiple myeloma. So that's how we kind of think about MGUS. Waldenstrom's completely like random though. So Waldenstrom doesn't have Crab criteria, but it does have the M spike, all right? And it's greater than 3. The big clinical differentiator for Waldenstrom's is hyperviscosity syndrome. They make so much IgM antibodies, and these suckers are huge. Like these freaking little things, they're pentamers. So you get a lot of them, whereas in multiple myeloma and MGUS, they're usually monomers or dimers. So when you get a lot of these IgM antibodies, there's so many of them that it actually causes the viscosity of the blood to go up because you have so many proteins. And so they can get like clots, like our hyperviscosity or sluggish blood flow in their brain. So they can get headaches, they can get dizziness. It can even kind of engorge or black up the blood flow in their retinal veins. So they can get big retinal veins that are enlarged on fundoscopy and blurred vision. And sometimes it's enough that they can actually inhibit the platelets and they can start bleeding, usually epistaxis or gingival bleeding. So those are the real big things to remember for Waldenstrom's. So all of them have an M spike. Greater than 3, Waldenstrom's, multiple myeloma. Crab criteria, multiple myeloma. No Crab criteria, MGUS. Hyperviscosity syndrome is Waldenstrom's.
Is there any other tests you would order to try and really differentiate them? Or are there any other really significant testing you would do?
Yeah, so that M spike is really critical. So we got the total protein and then we got the albumin, so we got the protein gap, right? And it just tells me I have lots of proteins. I don't know if it's alpha 1, alpha 2, beta 2 globulin, or if it's gamma globulin. The only way that you can truly tell is to get an SPEP. That'll tell me what kinds of, it'll specifically tell me if there's an increase in the gamma globulins or not. And then the next thing is I want to do a UPEP because it tells me if there's lots of gamma globulins in the urine. And the true one that has the most effect on the urine is multiple myeloma. MGUS doesn't have that effect on multiple myeloma. On the UPEP. And then the last one is the free light chain ratio. The only two that produce those free light chains is multiple myeloma and MGUS. And so if I do all 3 of these tests, it really will give me a clear idea. So let's say that I get the protein gap, it's elevated. Let's say I don't have any look at the clinical criteria for Crab or hyperviscosity. I just go straight to the SPEP. Elevated protein gap, look at the SPEP. If the SPEP shows that M spike and it's greater than 3, we know that that's only going to be Waldenstrom's or it's going to be multiple myeloma. If it's less than 3, it tells me it's more likely going to be the MGUS. From there, I would do the UPEP. And if the UPEP shows that there is actually an M spike, that means that there's little proteins that are getting into the urine. And the only one that has enough of those is multiple myeloma. So the UPEP will show an M spike, and that will only be for multiple myeloma. You won't really see that in Waldenstrom's, and you won't really see that in the MGUS. From there, I do the free light chain ratio, and the free light chain ratio just tells me how many free light chains you have in the bloodstream, particularly, that's it. So it kind of looks at like the prelude to the urine. And so if the free light chains are really elevated, the only one that has the most free light chains is multiple myeloma. It may be a teensy bit elevated in MGUS, but in Waldenstrom's, they don't make any free light chains and show that should be completely normal. So that's the way that I like to look at this is SPEP, M spike greater than 3 is going to be multiple myeloma or Waldenstrom's. Less than 3, more likely to be MGUS. Do they have Crab criteria? I like to do that first. No, probably MGUS. Crab criteria, yes, more likely multiple myeloma. Hyperviscosity syndrome, more likely to be the Waldenstrom's. Then I do the UPEP. If the UPEP shows an M spike, it's more likely multiple myeloma. If the free light chains are really elevated, it's more likely multiple myeloma. That's the way that I really like to look at these. But I think it's important to also remember that you can't only do electrophoresis. So when you do electrophoresis, right, it separates the gamma globulins out, or it separates all the different proteins into which one's the most elevated, and usually shows gamma globulins. It won't tell you which antibody is elevated. And so remember I told you in multiple myeloma and MGUS, the only antibodies that are elevated is IgG and IgA. And Waldenstrom's, it's IgM. So you have to actually do what's called immunofixation. So you do the SPEP, and then usually you do the SPEP with immunofixation, where they'll take those proteins and figure out which one of those gamma globulins is actually elevated. So if you get immunofixation, IgG, IgA are elevated, that's MGUS or multiple myeloma. If only IgM is elevated, then it's going to be Waldenstrom's. And so that's some things that you have to remember. So again, you get the SPEP, UPEP, free light chain. Just remember, when you order that, you get the SPEP with immunofixation, and it tells you gamma globulins are elevated or not in the blood or in the urine, free light chains are elevated in the blood or not, and then get the immunofixation to tell you which type of antibody is elevated.
All right, well, let's take this case one step further. We have the information. Now let's try and figure out what's going on with our patient.
Okay.
So we get the SPEP. We have M spikes present. We have a UPEP, and we see Bench-Jones proteins are detected. Free light chain ratio is greater than 100. So this would then indicate what, Zach?
That's definitely multiple myeloma.
Okay.
Because if you have the SPEP that shows the M spike, and you got the UPEP that shows the Bench-Jones, and that's the only one that really shows a UPEP that's positive, and then the free light chains greater than 100, that's almost, and plus the Crab criteria,
It's a slam dunk.
it's a slam dunk for multiple myeloma. But there is other things that you'd have to do to confirm the diagnosis. But for here, for sure, MPEP positive, probably greater than 3. UPEP positive for Bench-Jones. Free light chain super elevated. That's super supportive of multiple myeloma.
So there's more confirmation for multiple myeloma?
Yeah, I mean, with this one, I would definitely, so they did the SPEP, and then they must have done the immunofixation because they told us that it was IgG specific. So that's nice. I definitely know that this is multiple myeloma, but the only way that I can truly confirm this diagnosis is to go to another step, which is actually kind of look at the bone marrow. That's the only way that I can truly kind of confirm this process.
So what are you looking at then with the bone marrow?
So if I did a bone marrow biopsy, I want to see tons and tons of plasma cells that have infiltrated into the bone marrow. So if it's multiple myeloma, you want to see usually greater than or equal to 10% plasma cells in the bone marrow. And if it's Waldenstrom's, they're not technically plasma cells. They're like a B cell and plasma cell, like in a tweener, another tweener. That's what we call them, lymphoplasmocytes. And I want to see greater than or equal to 10% of those. So if I see greater than or equal to 10% of plasma cells, it's multiple myeloma. If I see greater than or equal to 10% of lymphoplasmocytes, it's definitely Waldenstrom's. If I don't see a lot of them, and it's like less than 10%, and it, again, I have the M spike that's less than 3. I have no Crab criteria. UPEP's not specific. Free light chain ratio is just a teensy bit elevated. And then they show me a bone marrow biopsy with less than 10% plasma cells. That's probably MGUS. So that's the way that I would kind of go about that step is, first thing, look at the clinical criteria, then look at your protein gap, get your SPEP with immunofixation, UPEP, free light chain ratio. From there, you determine which type it is, confirm your diagnosis with a bone marrow biopsy.
How do we determine if a patient is standard risk or high risk multiple myeloma?
Oh, geez, that's a good question. So you generally, when you think about this one, you like to look at like all the complications that they have, right? So usually most patients will present with that classic like Crab criteria. But I think the most important thing is to figure out the underlying type. So for example, multiple myeloma, a lot of the times we don't have a great reason, but we suspect that they're probably due to chromosomal translocations. The one that's a good translocation, if there, you could think about it like this, because no mutations are great, but this one at least causes a less severe form or the standard form of multiple myeloma is the 1114. So basically what happens is on 14, there's an IgH enhancer. It's an immunoglobulin heavy chain kind of gene. And then on chromosome 11, there's a cyclin D gene, and that helps with proliferation. You take that cyclin D gene, you move it over to the IgH, and it enhances this process. So now they just proliferate, but they also proliferate with that gene that produces lots of antibodies. So if I get that one, it's the best one. So I want to know, do they have 1114 translocation or not? Next thing is whenever you have tons and tons of proliferation or what we call increased cell turnover, you produce molecules that help us to suspect there's an increased cell turnover. One is LDH. Another one is beta-2 microglobulin. And then the other thing is, if you think about the shaka again, albumin, alpha-1, alpha-2, beta, gamma. As this starts to go up, other proteins start to go down. And so if albumin starts to go down, that means that you have super, super heavy amounts of gamma globulin. And that's also a kind of a poor prognostic indicator. So if I see a patient who has no 1114 translocation, that's not a good thing. They have increased LDH, increased beta-2 microglobulin, and low albumin. These are all factors that tell me that this is a poor prognosis and not a standard risk patient, and they're going to require a lot of different things. If I have a patient with a 11-14 translocation, a normal LDH, a normal beta-2 microglobulin, and a normal albumin, that's your standard risk multiple myeloma, and they'll probably respond pretty well to your classic therapies.
That's pretty interesting.
I know, yeah.
And it's like, best case scenario for the 11-14, but nothing's good. It's
there's all these other types of translocations that are much, much more severe. That's why you got to do cytogenetic analysis. So you always check the LDH, you check the beta-2 microglobulin, you check their albumin, and then you order a cytogenetic analysis to look for types of chromosomal translocations, and just cross your fingers that it's 11-14.
How do we treat a standard risk multiple myeloma patient with CRAB findings?
So you always got to treat the complications first, right? So you got to make sure that, if they have CRAB criteria, treat those things. So if they have hypercalcemia, we give bisphosphonates. Those are usually good for that, and hydrate them. So because they become super dehydrated, like this person's polyuric and polydipsic, you probably want to give them some IV fluid, some normal saline. And then from there, I put them on bisphosphonates. There's alternatives like denosumab, which you could also consider, but that's basically going to hit two things. One is it's going to stop the osteoclast from continuing to break down the bone, which will prevent lytic lesions. And on top of that, also help to prevent hypercalcemia. So that's what I would do for that one. For the renal failure, you just have to try to avoid further damage. So in this case, it's multiple myeloma related. You got to avoid things like try to limit NSAIDs to the patient if they have underlying diseases that require it. Try to avoid nephrotoxic agents like antibiotics, like aminoglycosides and vancomycin or amphotericin. Try to avoid contrast dye if they need to get a CT scan that's contrast studied. So those are really important things. But if they progress and they get worse and their renal failure is getting to the point where they're uremic, acidotic, hyperkalemic, hypervolemic, then you may have to go to dialysis. There's what's called high cutoff dialysis, and I've never seen somebody actually have to require it, but you can do plasmapheresis for a patient who has a severe renal failure with multiple myeloma. Usually we just do what's called a high cutoff dialysis, but you can consider plasmapheresis as well. Now, the other thing is, besides the complications, is you have to treat like the underlying disease.
Sure.
And so usually with these patients, we'll do chemotherapy. So after you kind of get their complications sorted out, you're going to start them with an induction agent. But you have to determine, is this patient transplant eligible? Because you could actually transplant in these stem cells to make normal plasma cells. So these normal plasma cells won't produce all these antibodies and cause all this disease. So if they're eligible for a transplant, you'll induce them, and you'll do what's called VRD therapy. And V is for, bortezomib, R is for lenalidomide, and the D is for dexamethasone. So you're giving them a chemotherapeutic agents, and that's going to hopefully kill a lot of these malignant plasma cells or lymphoplasmacytes, and hopefully that's going to reduce a lot of that tumor burden. Then from there, if you definitely are going to be getting a transplant, we hit them with what's called high-dose melphalan, which is going to kill off the rest of the types of tumor cells. Then we're going to send them to get a bone marrow transplant. Usually you're taking it from, it's allogeneic, so you're taking it from yourself. And then we're going to do that transplant. After that, you want to make sure that they remain in remission and that transplant doesn't fail. So you'll do maintenance chemotherapy for a while. And usually that's usually just lenalidomide. So that's kind of how we would do these patients, is we would treat the complications and then induce high-dose melphalan prior to the transplant. Then you're going to do the transplant, and then you're going to continue maintenance for a while until we can get them into remission.
All right, awesome. How about the management for MGUS and then Waldenstrom's macroglobulinemia?
So with MGUS, you're just going to do like maybe every 6, but probably more 12 months, probably once a year. I would do an SPEP, maybe a UPEP as well, and a free light chain, and just keep an eye on their protein gap as well as too. So look for CRAB findings and then look for that transformation. So again, you want to make sure that you watch out, especially the SPEP. That's the big one. So if they start to develop CRAB findings, that's concerning. And if you monitor their SPEP and you see, their M spike went to greater than 3, I could have converted into multiple myeloma. So they have that 1% chance. So I would definitely do some SPEPs and then watch out for the CRAB criteria. So maybe get a BMP, or I'd actually do a CMP to watch out for that calcium, watch their renal function, and watch the albumin. And then on top of that, I would also probably, if they develop any pain, get x-rays or skeletal surveys to watch out for some lytic lesions. Waldenstrom's, usually if they're not having any problems, just like MGUS, we don't really treat it, but Waldenstrom's, if they're not having any issues, we don't do anything. But if they develop complications, you treat accordingly. So the big thing to remember for this one is if there's enough IgMs circulating that they're causing hyperviscosity, headaches, dizziness, blurred vision, oronasal bleeding. That's an indication to do plasmapheresis. You got to remove all those IgM antibodies that are causing the damage and replace it with normal plasma. So that's what we would do only in hyperviscosity syndrome. Otherwise, you're pretty much just going to, if they really are developing symptomatic diseases, so they have anemia, they have neuropathy, they have other types of complications associated with this, then I may go the extra step and I potentially would do some type of like a rituximab-based chemotherapy. So that's one thing, but another one is the newer one, which are the Bruton tyrosine kinase inhibitors. So those are also really good as well. But basically what you're trying to do is you're trying to block these B cells from turning into plasma cells and shut down their production of these antibodies. And so that's the way we would do that for Waldenstrom's.
Awesome. Well, those are all the questions I have. One take for plasma cell disorders. That's it.
I know, man. That was pretty awesome. I think that, plasma cell disorders, in your lifetime, you're probably not going to see a lot. I mean, only in my small time, being a clinician, I've seen multiple myeloma once and I've seen MGUS a couple times. But, I think it's important to know because with a lot of these, multiple myeloma is probably going to be the most common one that you'll see. And I think it's really important to be able to identify this one. You can make a lot of a difference in these patients. And MGUS, it's important to know the reason why this is important to identify is because they do have a chance, though it's small, they do have a chance of converting into multiple myeloma. So I think these are really important things to be able to consider, especially for your boards.
All right, cool. Well, that's the episode. Let's we'll wrap it up then.
All right, man. Thank you guys so much for watching our podcast. Thank you guys so much for chilling with us and hanging out. And love you, Ninja Nerds. And yeah, Shaka, brah, Shaka. But thank you guys so much. Love you guys. As always, until next time.